All right. Yeah, it looks like we're good to go here. Let's get this here. All right. Okay. Okay, great. So what we're going to be talking about really quick as a kind of quick crash course is understanding capitated contracts. And essentially, I'm going to share my screen and show you a provision that will essentially, it looks like there is a delay of sorts. Let's see as we get this going here, impromptu situation. Okay, so I will share my screen so that you can see the provision I'm going to be talking about. Here I have some of my associates in the room with me, and they suggested that I share this experience on YouTube. So here we are. And so while we get this provision up and running for you so you could view, what we want to do is essentially understand the implication of the provision here that in an IPA contract, a capitated contract for Part B services, meaning not for hospital, but for physician level services, the proposed agreement here essentially indicates that there's the capitation of 34% of what Medicare pays. So what does that mean? Let's dissect it. So essentially, let me see if this is visible. It should be. Zeiss, let me know if you can't see it up there or if it's hard to see. Essentially, what happens is that Medicare, this looks pretty hard to see. Okay. Essentially, Medicare, CMS, will provide a set dollar amount called per member per month to a private Medicare Advantage company. In this case, let's say, Humana. And what will happen is that based on the location and then various other factors, Medicare will put a dollar amount for each patient that's assigned to or enrolls in Humana per month, PMPM, okay? So this is the Medicare Advantage payer first tier capitation. Now, what happens in some markets, and specifically California markets and other capitated markets, essentially what happens is that Humana will go ahead and contract with IPAs, okay, mini health plans, and pass down in a, there are different kinds of risk arrangements, but in the one that, the one that we're talking about, will pass down essentially, a certain percentage, whatever is agreed upon. In this case, 34%. Yes. So 34% of the $1,000 capitation is going to be paid to the IPA. Okay. Then the IPA is responsible for certain functions to administer. And so this agreement will go into what functions are delegated and what are the mechanisms for payment for those delegated services. And whether this 34% makes sense in terms of, actually modeling the risk against, the population type. And so that's what we're going to be looking at today. And so essentially this says that for certain functions, and broadly speaking, there are going to be 6 functional areas that are going to be subject to delegation, okay? The 6 functional areas are standard across healthcare operations whenever you need to, have run a healthcare entity. These 6 functional areas are essentially going to be part and parcel of any healthcare company, whether you're a single provider and on the island of Maui operating out of the basement, or you're a Fortune, 6 Optum, huge company, you still need to have these 6 functional areas implemented and running. So operations is anything that hits profit and loss. Compliance is self-explanatory compliance. Contracting and network, again, self-explanatory, contracting and network. Engagement, essentially, marketing, any kind of community engagement, patient engagement, grievances and appeals could be under engagement. Quality is essentially, these quality performance metrics, quality assurance, and kind of outcomes, right? Patient outcomes. And health services, essentially, the medical director's wheelhouse, the clinical delivery at a payer, for instance, utilization management would be under health services. On the provider side, you would have your medical director and kind of, the clinical teams delivering healthcare services. So in the scope of this delegated agreement that we're looking at, there are, sub-functions upon sub-functions upon sub-functions, down to specific sub-functions are delegated to either the IPA in this case, or MSO in this case, or are going to be on the part of the health plan to take care of. For instance, in carve-outs, when we're looking at a delegated model, want to make sure that we are getting reimbursed adequately for the administrative burden of administrating this kind of programs. And so with that said, what we want to do is essentially look at other areas of risk to mitigate, because by definition, capitated contracts are risk contracts, right? And so in order to make sure that we're managing the risk adequately, we want to look at, okay, well, what are the timeframes around recoups? What are some of the implications of STARS reductions, right? What are some of the supplemental benefits or optional benefits that are made available through the plan benefits that will further help the IPA mitigate, or actually implement appropriate utilization of care and kind of take a preventative posture versus a traditional reactive posture. And so this agreement sets the basis for essentially bringing on an IPA in the Medicare Advantage realm and going into the risk business. So this is part B, and the next level would be part A and B, part A, B, and D. This is a shared risk. And then we all the way at the kind of the greatest risk would be the globally capitated contracts. And these are depending on how care is managed and what kind of interventions are provided, how proactive is providers are engaged, and kind of the network strategy. One can really make a difference, in a way that is fiscally sound and in a way that is responsible, right? So the Medicare Trust Fund is not unlimited. So this is a starting point for talking about how do we want to demystify the business of healthcare and make sure we have more successes than anything else. So with that said, I am going to log off, and you know where to find me. Feel free to ask any questions.